สวัสดีค่ะยินดีต้อนรับทุกท่านนะคะกลับเข้าสู่ IAEA Course Series นะคะ Expert Mission Strengthening Optimization in Radiological Practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่6แล้วนะคะที่เรากลับมาพบกันแล้วเราก็จะสวิชเกียร์จากครั้งที่แล้วที่เราพูดถึงในเรื่องของ CT นะคะครั้งนี้เราจะมาพูดถึงในเรื่องของ Fluoroscopy นะคะแล้วก็ในเรื่องของ Procedure ใน Intervention นะคะซึ่งเราจะพูดถึงในเรื่องของ Dose Optimization แล้วก็ Dose Metric ที่เราจะเอามาปรับใช้นะคะแล้วก็เช่นเคยนะคะเราก็ได้รับเกียรติจากดร. Sam Brady นะคะจาก Cincinnati Children's Hospital เป็นหัวหน้านักฟิสิกส์นะคะที่มาเป็น expert ให้เราในวันนี้นะคะ Good evening Sam, nice to meet you again and welcome back after 2 weeks break. So this week we're gonna switch gear from optimization and dose metric in CT to the fluoroscopy and also the interventional radiology, which create some kind of like a lot of dose to the patient sometimes if we don't know what we should do. And this week you are going to talk about the optimization and also dose metric in those two areas. So welcome.
Thank you. Thank you, Tanya, for that welcome. Let me get my screen up. All right. All right. Well, as was mentioned, we have been spending quite a bit of time, last actually 3 weeks, on the CT scanner. So we're going to shift gears now. We're going to talk about fluoroscopy. And fluoroscopy is an interesting creature. So when we talk about image quality, which we're going to talk about today, we're going to go over the various different image quality metrics that you will come to realize are the same for all imaging modalities, but they are when we go to optimize image quality, they're going to be somewhat different, more so different in fluoroscopy than they would be in, say, CT and in the coming weeks when we do X-ray and mammography. So for our first session, I'm gonna define and we're gonna talk about how the very specific image quality metrics are approached in fluoroscopy, and then the second session for today, we're going to talk about optimizing the image quality in fluoroscopy. Of course, next week, as I'm sure Tanya just described, we'll be going over the dose quality, the dose metrics, and then of course how to optimize radiation dose in fluoroscopy, which, as she mentioned, can be a high dose, probably one of the more high dose procedures or devices in radiology. All right. So image quality metrics for fluoroscopy. Obviously, we need to just take a big step back. We say this every time because this is a diagnostic reference level. Forgive me, that should say DRLs, not DLRs. Diagnostic reference levels. That's kind of really why we're here. This is why we're talking about this over these last couple of weeks and for the next couple of weeks. As Thailand and, of course, everyone moves towards having national DRLs, where does image quality fit in this? Now, you may recall from the very first couple of weeks, we talked about how image quality DRLs do not make any assumption for image quality. They are simply an average of what's going on in your local hospital, regionally, and then of course in the overall state or the overall nation. And so we, in our local hospital, we need to make sure that we have the right and the optimal image quality. So when we report the doses to the national level, so they get averaged, we know that those doses are optimal for the image quality that we need for our diagnostic task. So DRLs do not make any assumption for image quality, but implicit in that is this idea that if most people have, say, for example, a 75th percentile of dose, then what we're saying is that the image quality at that level should be sufficient if 75% of all the institutions in Thailand can achieve that dose. And the same can also be said at the 50 percentile level. So it doesn't directly say anything about image quality, but it does say that we should strive to get our doses to that level, and then hopefully the image quality at that level will be sufficient for the diagnostic needs at your institution. So very specifically, talking about image quality for fluoroscopy, it's rather complex. When we take a picture with CT, even though we're taking lots of them as it spins around our body, they're all stationary pictures that get put together, and radiologists and other practicing physicians, when they see those images, they're able to see a static version of the anatomy. In fluoroscopy, that's not the case, obviously. In this case, we have to optimize image quality based on exposure time over the exposure amount, which we'll talk about next week more specifically about the radiation dose, how the system is used, and the different geometries that we face with fluoroscopy. Fluoroscopy, of probably all the imaging modalities, is the most widely differentiated system. So you can use fluoroscopy in a more traditional sense, where you get the typical C-arm, where you have the X-ray tube mounted on some kind of C-like structure that allows the system to get in close to the body and move around the body. And some type of detector will be on the other end, obviously the opposite side. And these C-arm type fluoroscopy systems can come in even different shapes and sizes. They can be fixed, where the imaging receptor and the X-ray tube cannot obviously move independently to each other. The whole system can swivel, but the system itself, the image detector and the tube, can't get closer. Or you could have a completely different geometry where it's the same type of C, but it's the bed, the actual table itself, is fixed to the system, and now the whole system can tip. You can actually do fluoroscopy in what we would consider traditional CT, where the system is still spinning in a CT geometry, but it's operating in live or real time to produce fluoroscopy. So when you look at just the whole spectrum of types of machines that we use in fluoroscopy, they're kind of a far cry from where we were, a little less than 100 years ago, where our poor radiologists had to stare down the the receiving end of an X-ray tube and get lots of radiation in their face. But the principle is the same. The idea that we're going to use real-time, live acquisition of radiation to depict both stationary anatomy and physiological effects. So what are the image quality metrics that we need to optimize for fluoroscopy? Well, as I mentioned kind of at the beginning, they're the same as every imaging quality metric that we've been optimizing for CT, and we will then, of course, talk about in the coming weeks for X-ray and mammography, namely spatial resolution, where we're trying to optimize the high contrast aspects of the image. And then, of course, there's the low contrast resolution, and then there's noise. So these are the three main principles. Now, in that, though, for fluoroscopy, we have two kinds of noise. We have the quantum noise, which is when you look at a static image, you obviously the noise that overlays the image, and that's what degrades the image, of course. And so typically in CT, X-ray, mammography, we're trying to get that noise out. But in fluoroscopy, because it's being acquired in real time, noise takes on a different aspect, because there's a temporal aspect as noise changes because of its stochastic or statistical difference from every time the X-ray tube creates a image. And we put all those images together and we run them in a movie, basically. So when we talk about noise, we're going to talk about the static effect, the overall quantity, the amount of noise in the image, and then the effect as it changes with time. So let's get the easy ones out of the way. Let's talk spatial resolution. So a traditional fluoroscopic system is going to have what we would call a resolution somewhere in the 3 to 5 line pairs per millimeter. And this is basically, now that we have digital systems, they either have the digital flat panel detector on the system, or you may still have an II, an image intensifier, the big tube on the top. But even on top of that, there's still a digital detector on it, a CCD camera, which are the same cameras that we have in our phones. So either way, if we're using an II, an image intensifier, or the traditional flat panel, they're both being they're both digital systems. And so because of that, we actually can see pretty good resolution. And here I just did a really basic math for you, but if you had a 23 centimeter field of view projected on a 1024 by 1024 matrix, you can see roughly a difference of two objects, either 0.22 millimeters in size or 0.22 millimeters in close or difference. So there's only a very small difference between their geometric location. So we can actually do pretty good with resolution in fluoroscopy. That said, and we'll talk a little bit more about this in the next session today, there are different ways in which we create these images. And one example for these digital flat panel detectors is 1024 by 1024. That's a lot of pixels. And so oftentimes we don't actually give you 1024 pixels in the horizontal and 1024 pixels in the vertical. We usually bin them and we average several together, say 4 by 4 or some kind of amount. So you actually get much smaller images, matrices. The image itself is independent, but the matrix itself is smaller, in which case the resolution will decrease. And we'll talk about that in the next session. But basically what that means is depending on if you're binning or not binning, your resolution will be either high or low. And if you're not binning, so you have the native, say 1024 by 1024, really good 0.22 resolution, the last thing you need to verify is that your spatial resolution is not limited by the actual display monitor. So if you're in an interventional room and you got this you got a TV or flat panel display hanging in the room across from the table, you need to make sure that it's a high enough quality, obviously big enough. If you're standing far enough away, the monitor has to be bigger and bigger. We're not really going to talk about that, but you just have to make sure you have the right monitor with the right pixel pitch so that the high resolution for the fluoro is displayed on your monitor. And then there's other things, once again, we're not going to talk about, but if you're in a room, especially an interventional room with lots of lights on, because there's some kind of maybe semi-surgical process going on, you need to make sure there's a lot of luminance or light coming out of those monitors so you can actually see the contrast in the image. So the monitor itself tends to be the weakest link in this whole process when it comes to seeing spatial resolution. So let's go through a little practice here. In fluoroscopy, the question might be, well, what is the ideal spatial resolution? So I'm going to put this little pattern up here. A lot of these patterns I've taken, they're courtesy of a gentleman, Phil Roush. He's a retired medical physicist. Came from Michigan, a state here in the United States, just a world-renowned physicist that specialized in fluoroscopy. And so by permission, I have several of his slides or images from his slides. So if I were in a live session, we were all sitting around back in Thailand, I would ask you what this is. And it might be difficult for you to identify what this object represents. Is that a number? Well, maybe, right? 12, 13, 14. Yeah. Now that I see the numbers next to it, I go, yeah. I think that's a 13, right? But what if I say, nah, what if I give you this image, this fluoroscopic image? Now you might say, well, no, that's not a 13. That's an A, B, and a C. Those are letters. So the point here I'm trying to make is basic imaging metrics alone. This idea of spatial resolution, image contrast, noise, low contrast noise, all of these basic metrics that we've talked about, we presented actually several weeks ago and that we're now applying at each of the modalities. they do not always, optimizing those single metrics alone do not always improve image quality in general. For example, in this case, if we sharpened that image, yeah, you could probably tell the difference if that's a 13 or a B. So we could probably make it a little better. But if I can't, having a little bit of context, adding more to the image helps you still interpret this image, if you were a radiologist, even if the image quality was low. And what you're going to find out in fluoroscopy is we can't necessarily optimize the image as much as we can in X-ray and mammography or CT. And that is because we're doing this in real time. So the same tools that we've been talking about with CT, and we will talk about in the coming weeks with X-ray mammo, aren't as readily available to us in fluoroscopy. And that's why it's kind of an odd creature, fluoroscopy, to talk about optimizing image quality. What we're going to talk about today is about how we, the human, visualize or perceive images. And if we understand the human visual perception when it comes to image analysis, then we can then adjust certain parameters on the fluoroscopy system, which we'll talk about in the next session, to better improve overall image quality. So we know image contrast, as we've been talking about this with CT, is governed by the tube voltage. So in CT, we always said, or we were saying, that if we acquire everything at 120 kV, but then we change and now we start acquiring everything at 80 or 100 kV or some lower kV setting, the image contrast would pop. It would show forth stronger. And so kind of one of the take-home messages for CT was, now that in the modern era, we have really strong, powerful CT scanners with strong, powerful X-ray tubes, we don't have to rely so much on 120 kV as much as we can do more 100 or 80 kV. Problem with fluoroscopy is you can walk into any fluoroscopic system, there is no kV knob. I can't sit and go, oh, I want 100 kV, oh, I want 80 kV. That's not how fluoroscopy works. Fluoroscopy is governed by the thickness of the patient. So depending on what part of the body we're imaging, or the type of patient, if they got a big belly or a small belly, the system will automatically do its best to keep the image the same. So when you're looking at the monitor in that room and you pan from, say, the chest, which is mostly air, so not a lot of attenuation, to, say, an abdomen, even if it's a big abdomen, the system is going to change the dynamics of kV, MA, and a few other things so that the image brightness stays the same. Now that's important for the radiologist because the radiologist it's the same for any one of you that have been indoors all day and then you walk out into that beautiful Thai afternoon and it's real sunny. The first thing you're going to do is, at least for me, because I have blue eyes, I can't see for the first couple of seconds until my pupils constrict. And it's the same concept. If we were panning from a really big from a really big abdomen where the system's pushing a lot of photons, and then it shifts into the chest where there isn't, the image quality, the screen itself would be extremely bright, like staring into a light bulb. So fluoroscopy is really good at keeping that constant. So the radiologist can move wherever they need to, and they can adjust the patient however they need to, and they get pretty constant image quality. And that's great. The system handles that. But that means we do not have the same tricks that we've always been using. We cannot physically adjust the kV. So how do we optimize contrast? Well, this is all based on the human visual perception. So how does the eye perceive contrast? Now, if you look at these two squares that I've placed here, I would ask you, do these two squares have different contrast levels? And you might say, well, they may or they may not, but for all intents and purposes, they look the same to me. Now, when I place the two together, now I would ask, well, which one's the lighter, higher gray, the brighter gray scale, or which one's the lower? And you could easily identify them now. You can say, oh, I see the one on the right. That one's, to me, a lighter gray or brighter. And the one on the left is a darker gray or, well, darker. So why is it that we can see the difference here, but we couldn't readily see the difference here? Well, that's because of the way our eyes work. They have what's called a Mach band effect, actually named after a gentleman named Mach. His last name is Mach, and that's why we call them Mach bands. A physicist, if I believe. But the idea here is the way our eyes, the cones and the rods in our eyes, and how they're situated in our eyes and how they're focused in on our fovea, how all of that is aligned in our brain, or our eye, that's what gives our body the ability to see edges. It's based on this idea that as light passes into our eyes and it passes through an area that inhibits or strikes a certain aspect of our ganglion cells that causes an inhibitory process, then we're going to see less light. Therefore, it's going to be darker. And if it's going to be brighter, if it hits the excitory, I can speak, I promise. The excitory centers of the eye or the ganglion cell, then it's going to appear bright. And so depending on the spacing of the receptors in our eyes and the pattern that we're trying to see that's coming into our eyes, the light coming to our eyes from the monitor that we just acquired the image from the patient, that will give us an ability to see edges. And this distinction, this strong edge effect that you see here, whereas you didn't see it a minute ago when they were separated, is based on this Mach band effect. It simply exaggerates edges. And this is what really helps our eyes or our brains perceive contrast. It's the edge. And so when you take kind of a step function here, where we're going to go from a low grayscale to a bright grayscale or a more white color, and all I'm simply doing is adjusting the amount of gray. So I'm going from dark to white, and I'm doing this in a very specific manner. I'm just adding maybe 10 or 15 grayscale levels. If I simply take and I measure and I sample each one of these using the computer, I see these nice, strong edges. Obviously, I'm transitioning from one grayscale to another grayscale. There is no gradient. It's one value, then another value. And each of the values are 100% uniform from edge to edge. But the reality is, if you look at this, our eyes see a difference at the edge. On the right side of each of these edges, the light or the pattern looks brighter. On the left side, the immediate left side of each of these edges, it looks darker. In other words, our eyes see this exaggeration, an exaggeration of low light and high light at an edge. And this is that Mach band effect. This Mach band effect is what really gives us the distinction or the distinctiveness in an object. We as humans, we basically see contrast in two ways. One is the distinctiveness of the edge, and two is obviously the distinctiveness or the difference between the object and its background. And we kind of talked about this. We didn't name it. We didn't call it a Mach band effect. But when we were doing this with CT, and we talked about the new reconstruction techniques out there, iterative reconstruction and deep learning, and how a lot of radiologists have struggled with these new reconstruction techniques because we are getting rid of the noise from the image. We didn't want that noise in the image. And so now we can see the anatomy more clear. But through that process, we have made the edges a little softer. And so we've actually diminished this Mach band effect. And so to the eye, these images are not as pleasing because we're reducing one or of the two the ways we visualize contrast. We are reducing the amount of, or the ability for our eyes to see contrast because we're removing the edges. So let's talk about that. Let's give an example of how edges can show contrast. So on the left-hand side, I have a circle. Well, I have a variety of circles, but the circle itself is a lighter or brighter grayscale than the background. And here you can see just using a nice plot, you can see that the background and the object itself are two very distinct grayscale levels. Now, this same circle is right here. I promise it's there. But look at my plots down here. The difference is there is a distinct edge on this object, whereas on this edge there is a gradient. I have slowly changed the grayscale value from background to the value of this circle, and I have made it very gradual so that there really is no edge. Now, if you kind of lean back to your monitor, you could probably see that there are a bunch of circles in this image. So what I'm going to do is I'm going to peel those circles off, all those annular rings. They're all gone now. So here you see you have a nice distinct edge against the background. Same left, same right. Now I'm going to add a ring. You can maybe very faintly see it here. You can see that I've added it here on the plot. Now I'm going to add another one, add another one, add another one. So now you're seeing these rings as they're approaching. Why? There's a distinct edge. You can see this edge. I'm going to add another one, and another one, and another one, and another one. Now I'm going to add the final ring. And all of a sudden, they all technically disappear. Now, you've seen the rings, and so maybe if you kind of sit there and squint a little, you can say, hey, I can see those rings. And if you lean back away from your monitor, our eyes see contrast better when we pull our eyes back, and we'll put a little bit of distance. And so here you can see that they're gone. So let's do that again. This is the effect, that mock band effect. It gives us the ability to see edges better. And so what happens to an object if we take away the edges? Well, we're going to talk about that in a second. But let's talk about, so the other, I said there are two ways our eyes perceive contrast. One is edges, and the other is the background, right? So in fluoroscopic images, as we collect them, there is typically going to be what we would call a heterogeneous background. There's just a lot of different gray scales, and then there's going to be an object or something that we're trying to visualize. A PICC line going in this case, maybe going into the stomach and the duodenum, and we're trying to image. We're going to talk a little bit about how we can image better, obviously, by applying contrast. But in general, the object itself is not in a traditional grayscale, uniform background. And so we have to be able to differentiate contrast when the background itself changes. In the previous image, I kept background constant. So here I have an image. It's got words, black and white. What I'm going to do is I'm going to take this B and I'm going to place it right here. So this B right here in the word black is the same as these three B's. And I'm going to take this H from white, and this H right here is going to be replicated across here. So what we see here is the B, because it's in a uniform background, that B here looks the same as all three B's. So all of these B's look like they have the same grayscale. Whereas the H, it looks the same here in this uniform background, but when it is placed in this background, which is a different uniform color or different uniform luminance, it looks slightly different. And then of course, as it's right there across the edge in this heterogeneous area, it looks different. The reality is, as you can probably guess, is the B's are the same and the H's are the same, albeit slightly different, but they are the same. So when I project them into different backgrounds, the contrast to our eyes changes. H looks brighter or lighter here than it does here. It's not true. The H is the actual same. So how do we get around this? We are looking at an object in a fluoroscopic system, and the background is going to be constantly changing, right? Because we're imaging in time. So there's really two ways that we can control contrast. So I'm kind of getting to a long-winded way to get to the point here, right? There are two ways we can control contrast. We can't dial KV, right? And we know now that we want edges and we want to control the background as much as possible. So if we can control these two things, we can optimize. So the first thing, of course, is if we can't control the background, we can control the foreground. So this is predominantly why we inject iodine or barium if we're doing like a barium swallow or something. And so we're imaging down in the gut and the abdomen. So what we're going to try to do here is we are going to try to optimize the contrast for the object itself that we're imaging. So maybe in the heart, for example. The reality is if there was no contrast here, could you see this heart? No, I can't. No, not really. And that's just because all the soft tissue organs attenuate radiation similarly. They all have basically the same electron density. And that does not bode well for X-ray. When you look at a non-contrast CT, everything kind of looks the same. You can kind of pick out the differences. And of course, you know where the anatomy is, so you know where the organ should be. But here in fluoroscopy, because we can't dial in that KV, we have to do something else. So we're going to inject contrast into the body. So we're going to A, either control the contrast to the object, or B, we're going to control the background. And we'll do something like a subtraction angiography, where now we acquire the image, we get the mask, we apply the mask, and then we inject the contrast. And now obviously we subtract out the background. And so nice here, it's nice and rigid in the head. And so we don't have to worry as much down in the body. If we're doing, say, I don't know, anywhere in the kidneys or something, you're going to get some kind of movement. And so therefore you're always going to have a little bit of motion artifacting. That can occur, of course, in the head. But for the most part, what we're dealing with here is we're reducing the background. So we either one, inject and make the foreground stick out, or two, we get rid of the background, make it uniform so that the object itself has the same contrast throughout. Okay, so we know that we want to have distinct edges or we want to have distinct backgrounds. So we've just affixed the idea if we can't control so how do we control the background? But what do we do if we cannot control either one? What if we cannot control the edges, or doing subtraction angiography is not an option or really not necessary? This is where noise actually becomes a helper for us in fluoroscopy. Up to this point, we've always looked at noise as a bad thing. And it's because noise always obscures anatomy or a physiological effect. So what we're going to deal with now, because this is real-time imaging, we can see the difference of one object to another when it's being played in time. And so what we're going to do is we're going to look at an object here that has no contrast, zero contrast, the object to the background. There are no perceivable edges, and we cannot control the background in this case. So what we're going to do is we're going to induce contrast based on noise. So in this image, this background, I have embedded an object. And I'd ask you if you could find it if we were live, but in person, but you probably can't see it. So what can I do? Well, I can turn my fluoroscope on. I bet you can see the object now, right? So the object starts at the top, and it does this fun little circle. Why could you see that? There is zero contrast difference between that object and its background. The only reason you can see that is because it's moving. So in this case, the object is moving, the background is fairly stationary. That's not always necessarily the same. We're not reaching in and jiggling the patient's heart or moving their kidneys around. Actually, what we're doing is we're moving the noise. Noise is random. We call it stochastic, right? It's random. So every time you acquire one image, you get a certain noise pattern. Now, if you acquire the exact same image, So you haven't physically shifted the body. You're doing the same image. The anatomy, the physical aspect of the body hasn't changed, but the noise, of course, changes. So speed that up, and now we're doing that 30 frames a second, 15 frames a second, whatever your pulse rate is. Now you are keeping the anatomy mostly stationary, but the noise itself is changing. So the effect of what we were just doing a minute ago, moving the object, is now going to be different. Now what I'm asking you to do in this example is tell me how many sevens, how many number sevens can you see in this image? Well, what happens if I go like this? Now what I'm doing is I've injected a lot of noise. There's a lot of numbers there that are not sevens, but the sevens are stationary. Given enough time, you could probably count the numbers as sevens, right? And so here they are just highlighted. I just injected iodine into my body, into my patient here. And so now you can see the iodine enhanced sevens. So the idea here is in fluoroscopy, we have really low dose imaging. And we need to, because if we're going to be doing fluoroscopy for 20 minutes, 30 minutes, an hour, 2 hours, whatever the interventional procedure is, or whatever the general fluoroscopic procedure, you're trying to do a reduction or something, in a pediatric patient that's having some problems in their abdomen. The idea here is you're going to be imaging more than just one shot, like you do an X-ray, or 20 or 30 slices in a CT scanner. You're going to be doing this in time. So each image has to be low dose. So the noise content is going to be actually pretty high per image. And that's okay, because what we do now is we make the noise vary with, well, we don't make it, it just does vary with time. And so the object itself will stand out more. All right, so those are the three things we talk about: resolution, low contrast, and noise. And that's for general fluoroscopy. So just real quick before we wrap up the first session, let's just talk about how that applies to one of the more unique ways of doing fluoroscopic imaging, and that is creating a CT with a fluoro system. So on our traditional, well, not our traditional, but our typical C-arm CT or fluoroscopic system in an interventional room, what's going to happen is they're robotic, and so they can actually move through a specific range. You can see here it's actually going to go through not quite 360 degrees. It's going to go through, so it's starting here, and it's going to go about 270 degrees, maybe a little less. And it requires more than, you remember, we need not 180 degrees, we need 180 degrees plus the length of the detector. And once you have that, you can create a tomographic image, so a true transaxial image. So when we consider this aspect of fluoroscopy, we look at the, I don't know where that 5 came from. It's just floating there. My apologies. Basically, what I'm trying to show without that errant 5, when you look at a traditional CT scanner, the system itself is far superior in every respect except for resolution than a flat detector CT, or this fluoro-enabled CT scanner. In other words, these systems, because they have these really, if you have these nice flat panel detectors, these flat panel detectors are actually, not only are they bigger, but they're really high density, lots of little teeny dexels or pixel elements in them. And so you can actually get really good resolution in these systems. That said, they're low dose, they're not a true 360, and so they are limited in other respects. So just looking a little bit here, conventional CT scanner, if you look at the distinctiveness of these patterns, so here's 8 lines per centimeter. It can see that, but after that, it really falls apart. You really can't see the difference. But on the C-arm system, even though it's binned, so this is its poorest, its worst resolution in a binning acquisition, it can see 10 lines per centimeter. You might even argue you could probably maybe see the 12, but that might be a little bit of aliasing. You unbin it, you could definitely probably see this one, maybe even the next one. So even in its worst showing, these C-arm CT scanners, the the fluoroscopic systems that acquire a tomographic or a CT, they are nice spatial resolution. Where they kind of are limited, as we talked about with the CT, is not only the field of view, you just have a specific detector. The detectors themselves will have a lot more artifacts because they don't do a full 360 rotation. That's why you see these ringing. And the true contrast differentials kind of they're a little lower. So you get really good contrast differentiation throughout here, where it's still good. It's still comparable, I would argue, but maybe a little lower. You might not be able to see these two features right here, but yet you can distinctly see them on a regular CT scanner. And so part of that is, of course, the lower quality, lower dose, the noising effect. But also, if you look at some other aspects, the edges are crisper because the resolution's better. Whereas you can see on the regular CT, the edges are not as strong because the resolution effects. And so these images look a little softer. And so that goes back to that mock band effect. And that was the last image on that one. So overall, contrast or spatial resolution, contrast, and noise in fluoroscopy are it's an interesting creature in the way we will optimize it. So in the next talk, we're going to talk about and give you actual tips on how to physically optimize those effects. But those are the same three principles that we've been talking about in CT as we will now talk about in X-ray and mammography. But the idea I hope to give you in just this short talk was that we actually are more reliant on our eyes in fluoroscopy and the way our brain processes the image than in any other modality. And so we have to remember that when we go to the next talk, as we now try to optimize these three features. So that's all I got for you on this session. We'll see if there's any questions. I turn the time back to you, Tanya.
Thank you so much, Sam. This is like an art that you need to okay, try to enhance the edge and control the background for you to see things better. It's like an art, like when you're drawing or design some poster or something, right? So which means it's going to be difficult to control the radiation dose.
Is it difficult? The answer is no. And admittedly, obviously next week is the dose talk, so I don't really talk a lot about radiation dose. There are a lot of tricks because now, so the next talk, we'll talk about how the system actually puts the image together based on resolution, contrast, and noise. But there are a lot of different types of knobs. We don't have a KV knob. We don't have an MA knob, but we do have other things we can do, which we'll talk about in a minute. But for example, we can change the distance of things, and we can change how fast we acquire the image. We can change the rate, and a few other things, which we'll talk about in a minute. So I would say no, we can still actually do really good dose control in fluoroscopy, which we'll get into next.
Okay, sure. So let me see, seem like we don't have any questions for now. So maybe we can go for the next talk, and maybe we can have like a wrap up questions.
Yeah, I think these two talks really kind of have to come together, and then you'll have the bigger picture, and then we can really get into maybe a discussion. All right, let me get rid of my first talk. All right, and share. All right, you should see my screen now.
Yes, I can see your screen.
Perfect. All right, session 2. Actually, this is the 12th session. We've been going a long time, haven't we? Just spread out over time. It doesn't feel so much. So anyway, thank you. So now, image quality optimization. So that was fun. That was all fun. We talked about the 3 principles, but really, what does that mean? How do we optimize it? Okay, there you go. I gave it to you. There's your answer. You got to get every one of those little boxes, and you just optimize each one of those boxes, and you get fluoroscopy image quality. And you might be thinking to yourself, that's crazy. And the answer is, yeah, there are a lot of little moving object or parameters that we have to optimize. So if you remember, we talked about this in CT, how we have this interconnective diagram. And it's the same thing for fluoroscopy. When you're trying to consider the major components of this, image quality, which we just talked about, the same metrics of image quality, noise, resolution, etc. And then patient dose, which of course we'll talk about next week, but that's the second most important thing. And of course, when we're talking about diagnostic reference levels, that's really the focus of this entire mission or this session, lecture series. But if you notice something, and here I just give you the acronyms. There's a bunch of acronyms written out here. For example, EERD is the entrance exposure rate to the detector. So that's the amount of photons that after it goes through the patient, how many photons or X-rays actually strike the detector. And so when you get this talk, you'll just be able to see that's just a simple list of all of the acronyms. But the point here I'm trying to show here, if you actually dig down and start looking at the interconnectivity, there is actually no direct relationship between patient dose and image quality. And that's the interesting thing about fluoroscopy. So the dose to the detector will affect the amount of signal to noise ratio we get in the image. So the pleasantness of the image. And that obviously directly affects the image quality. The other thing that affects image quality is KV, as we mentioned, the contrast resolution. Well, that KV is affected by the patient size. And the system will then adjust the amount of photons it needs, radiation output, so that the KV will be accurate, so the contrast will be proper, so you get the right image quality. So there is an indirect link. Everything is indirectly linked to image quality to dose. But there is no direct link because, like I said, there's no KV knob that we can turn. There's no MA knob that we can turn in fluoroscopy. So good image quality and good patient dose are not directly linked. So let's talk about how we can optimize at least the image quality for today and then dose next week. So what do we need to optimize on a fluoro unit? Well, we need to talk about the type of detectors. There's two major detectors out there. We need to talk about collimation, the use of a grid, modes of operation. And what I mean by that is the different magnification modes and the way we image, either continuous fluoro, so it's just always on, or we pulse it. We send in short bursts of radiation and we create these images and we just add them all together like a movie, like a cinema or a cine. And then we're going to talk about how the system controls the KV and the MA. The system itself, we used to call it the auto brightness control, ABC. That's kind of more of an older acronym. The more modern acronym is the automatic exposure rate control, or the AERC. And this will be directly affected by the type of filtration used in the system. Whoop, didn't mean to flip over too quick. The amount of filtration, and I meant to write KV and MA, so that's my apology. I said it out loud though. So the AERC will affect the filtration, the KV and MA. So this right here is kind of the list of things we're going to go over today. So let's talk about the types of detectors. Now, you get the system. You don't really get to pick which detector unless you're the person that buys the system. But there are two types of detectors, and they each have their strengths and their weaknesses. So let's go over them real quick and how they affect image quality. All right. We have the image intensifier, which is the big unit, the big system, the big detector that sits on top of our fluoro systems. It's basically a vacuum tube. It's a big empty hollow system. It's got your, it's got your indirect crystals on top, usually cesium iodide. So when the X-rays come in, they strike the cesium iodide, they get turned into light. That light gets turned into electrons. Those electrons are accelerated through this vacuum, and then they come out the other end, and there's usually a camera, a CCD. Like I said, it's kind of the same as the camera we have on our phones right here on the back end, and then that goes off and gets digitized. Whereas a flat panel detector, it is just a bunch of rows and pixels rows and columns of little what we call dexels or pixel elements. And then they're all read out based on all the electronics coming off the side of it. So what are the pros and cons here? So the image intensifier, or the II, well, actually this is how, forgive me, that's the next slide. I got a little ahead of myself. So how do the systems create the image? Well, I just kind of talked about the photons come in, cesium iodide converts the light to electrons, so they are accelerated through, and then the image comes out on the back end. It's the same as the flat panel detector. These flat panel detectors have a cesium iodide set of crystals on top. And so the X-ray comes in, creates light comes out, we collect that, and that's what we turn into a signal. This is called an indirect conversion. There is a direct conversion flat panel detector. They're typically called CMOS units. And there are a few of them. You can actually buy flat panel direct detector fluoroscopic systems. They're usually mobile units. I can think of one vendor that sells them. I don't know if any others have them. The system is a little better in the sense the X-ray comes in and it doesn't get converted to light. It just gets straight turned into signal. The X-ray comes in, it interacts with the structure, the amorphous selenium, and you get an electron that goes to one end, and a lack of electrons will accumulate on the other end, and that creates electricity, creates a charge, and that charge is what we measure out. So we get really good spatial resolution on this, but the radiation, the efficiency of converting these X-rays into signal is actually a little lower. By and large, what you deal with every day in radiology or up in the interventional labs, you're going to be dealing with either these flat panel indirect systems with cesium iodide or the II, which are also cesium iodide. All right. So how do these all compare? So indirect flat panel, this guy in the middle, is best for imaging fast moving objects, which is for most fluoroscopic flat panels. Direct flat panels, this direct conversion, are best for imaging stationary. So let's look at that. It makes more sense when you just put it in. Here we have, so this gentleman I mentioned, his name was Phil Rausch, Dr. Rausch, great guy. We kind of came up with it. He called this the Rausch phantom. Basically, it's just a couple of PMMA phantom blocks that cause the system to use a specific KV, but it's just a car on a track that goes in circles. It's a toy. Probably took it from his son or his daughter, and it just goes in circles on top of on the fluoroscopic table. So he can capture that car in motion, and then obviously he can turn off the car and it can just stand there stationary. So what you typically use is either an II, so stationary, pretty good. Motion, it's definitely going to be blurry. And the same with indirect. We mentioned that you're going to get pretty good sharp edges in motion with an indirect. Stationary, once again, still pretty darn good. And then the best stationary image of this car, of course, is going to be the direct conversion, but motion wise it's really slow, and that's just because to convert an X-ray and read out the signal, it's a little slower process, so that's why it's a lot more blurry. So ultimately we're using these two systems. I would argue when you look at these four images, they're fairly comparable. We'll talk about this more, but one of the things that you might notice from the top row to the bottom row, the left column, the indirect to the right, is there's actually a little bit less noise over here. And that's one of the hallmarks, one of the absolute strengths of an II, is because of the way it collects the signal in a large field of view, and it focuses it down to a really small detector. The noise itself is not a large component to the image. Whereas on these guys, the amount of noise depends on how many of the actual detector elements you either average or bin together, or you don't average. So, but we'll talk about that in a moment. So those are the two things. Obviously, you just use the system you get. It's got an II on it, or it's got a flat panel. But the way we use those now depends if we have an II or a flat panel. So for example, II systems have a limited dynamic range. What does that mean? The amount of grayscale from black to white is limited or truncated in an II system. And that is why if you image, for example, through the lungs, or maybe at the edge of the body where we have an obliquity, where our bodies kind of roll off, you can get these really strong white areas, especially if it's out into, off the body. So there is air where there's nothing between the detector and the X-ray tube. Whereas in the flat panel detector, you have a better dynamic range. And that is purely based on the fact that we can digitally change the post-processing on these flat panel systems differently than we can on the II. So knowing that you have an inherent difference in the way we can project or we can present the grayscale, collimation is actually very important, especially with an II. So here we are, we're imaging this little kid's face. And if you are collecting signal or part of the image where the air or there's direct irradiation of the detector to the X-ray tube, so there's basically no attenuating principles, pathways, no direct attenuating pathways through the body, you get this bright white. Now that bright white, you might think, oh, well, it's not that big a deal. But if you look at the structure, the overall contrast of this image compared to the contrast of this image, there is no difference. The KVs are the same, MAs are the same. The only difference is we put the collimator blades in. And those collimator blades are in now, and you can actually get and visualize a little bit more contrast. And that's just because we'll talk about this in a little bit towards the end of the talk. I'll give you some examples. But our eyes, when you put a lot of bright light on it, remember that inhibitory and the excitatory parts of the eye, it can cause the loss of signal or detail. And so we want to minimize the amount of this white light. And that is very much so true with the intensifiers, the image intensifiers of the II systems. Oh, and just as a caveat, I know we're not talking dose, but when you use collimators, of course, you're obviously reducing the dose to the patient because you're reducing directly exposed areas of the body. But we'll talk about that next week. So collimation improves contrast resolution. It improves contrast resolution by 1, decreasing the amount of noise. So you get much more scatter from these parts of the body that are being irradiated as they scatter into the main field of view. You remove the amount of scatter that you would have had from this part of the body, and you just get a better contrast to noise resolution. So using tight collimation, then the other way to remove the noise is using anti-scatter grids. We'll talk about that in a moment though. So a word about collimation. Most systems now, especially the newer systems, allow you to buy what's called a virtual collimator. And now this is mostly a dose issue. And what this means is, say you're just imaging, you have let off the pedal, so you have on your last image hold on the screen, you got this image. But all you really want to do is see the center part. In an older system, you would then step back on the pedal, and then you would push your collimator, your little tab, your little toggle, and then the collimator blades would come in, and you'd be happy, and you would keep going. But in reality now, if we collect this, we have the last image hold, not stepping on the pedal. We can then put our collimator blades in, and these virtual lines, these dashed lines will come in. And wherever you put them, that's basically telling you the next time you push on or step on the pedal, that is what you're going to see, only this. And so it allows you to pre-collimate to the area of interest, assuming the body stays stationary. And then the next time you push on the pedal, you get the image you want. So it saves patient dose. So one of those things that I recommend, especially in pediatrics, but as you buy new equipment, always ask, do you have virtual collimation? And I hate to say this because every vendor calls it something different, but they all, if you ask enough questions, they all go, oh, the salespeople at least, they'll eventually realize what you're talking about. But this is a really good way to reduce dose to your patients. And I personally think it's a must when it comes to pediatrics. So if collimation is not an option, in other words, we want to get rid of that extra white in the image, but if we cone in, well, we're getting rid of the anatomy, and maybe that's actually what we want to see, where the image is being kind of washed out with that extra white. Well, we have the option, especially on your interventional systems, especially in like cardiology, which I know we're not necessarily talking to cardiologists, but you have different ways to do wedges or equalizing filters. So depending on the type of fluoroscopic unit you have, you may have these different special tools. So here, maybe we want to image along here on the heart, but if we put a collimator blade right here, then we'd be removing these arteries from the image. Excuse me. So if we slide a wedge in, we're equalizing the image. And so we're adding more attenuation here, which is okay, because that basically just means there's not as much white. We're reducing the dynamic range. Now remember, this is especially important with IIs, but it can still be an issue with flat panels. And so having these tools, equalizing filters and wedges, once again, those are things you just have to see when you buy your equipment if it has those options available. All right, so collimation is usually step one. You get things collimated, you get the anatomy nice and localized. Now you've improved the ability you've enhanced your chance for good image quality greatly, because you're looking at the anatomy, you're getting rid of the extraneous scatter that would come in, and you're reducing your dynamic range so that the system can produce a good quality image with the right amount of grayscale. So those are just very basic, good quality steps as technologists know and as they use as they're operating the system. For those of you radiologists that are very hands-on and you like to manipulate the system, then that's just, step one is to get a good collimation. Okay. The other way to reduce the amount of scatter in the image is a grid. Now, we've talked about these in the past, way back in the day when we introduced it. Grids are much more important in fluoroscopy, X-ray, and mammography, and they're unique in all three of those. When you compare the types of grids to these main three X-raying systems, fluoro units are kind of right in the middle. When you look at the ratio, these values, which is the number, it's a ratio of the amount of grid lines and the grid spacing, so the place where the radiation can get through. The higher the ratio, that means the more finely spaced they are, the closer they are. So therefore, the more grid lines that would be in the image. And that's okay. The higher the number, that means less photons will get through, therefore less scatter in your image. But that also means less primary radiation that would go right from the X-ray tube, right through the body, and right through the grid to the detector. And so if you're actually reducing some of that, then the system has to compensate by putting more photons into the system so that you can get a good quality image. So the higher the ratio, the more radiation we need, therefore the higher the dose to the body, to the patient, to create the same quality image. And so because fluoro is real time and we're acquiring lots of images, they tend to be somewhere in the middle. Generally, a little lower than your stationary X-ray units, your DRCR systems. Mammo are low, but that's because it's just really low dose or low kV. We'll talk about those in a couple of weeks. All right, I just described that. Okay, so most systems will either have a physical way to remove the grid, or if you're lucky and it's a newer system, you can just push a button and the grid will move in or move out of the field of view, but you don't actually have to physically take it off the system. For the systems that require you to physically push a button and pull it off, or sometimes they're just literally clipped on, you have to take them off the detector, off the flat panel. That's great and all, but two things. One, if the system's wrapped for sterility because you're ready to go, you're say in an interventional unit and you're maybe in a hybrid surgery unit, well, that's no good, because if the system's wrapped for sterility, you can't get you can't get the grid out. And the other thing is, a lot of people don't like to take them off, because when you take them off, where do you put it? You put it on the side and you forget about it and it gets lost, it gets damaged. And so this concept of being able to remove grids it's actually pretty archaic. So the question is, should I remove this grid? Hands down, when you're imaging adults, no, you leave the grid in. Bigger bodies create lots of scatter. Lots of scatter needs to be reduced. You can only reduce so much by collimating. Most of it has to be reduced by using a grid. So no question, if you're an adult imager, you're going to keep that grid in. However, when we talk about pediatrics, the old adage has always been get the grid out, because if it's a small body, it doesn't produce a lot of scatter. But because the grid's in, we need to use more photons, therefore more dose to the little kid, to get the same quality image. And so we said, well, if we don't really need it because the kid's not producing a lot of scatter, take that grid out. Let's save the kid some dose. So that is the answer generally. Should you do it? Pretty much always. But what if the image quality suffers because you take the grid out? Should you then take it out, even if it does mean there's going to be a little bit more radiation dose to the patient? So a study came out from Keith Strauss, actually here at Cincinnati Children's a couple of years ago, and they took 3 piglets that were of size that would be comparable to either a newborn baby, a 3-year-old, or a 5-year-old. And what they're doing here is they're going to go in, they're going to catheterize them, and they're going to inject iodine. And what the task was for the interventional radiologist was to count the level of branching, first level branching. So off the main artery, the first level, and once it branches again, the second level, and if it branches again, third level or higher. And so the question was, how many branching orders can you count with a grid and without a grid? And then, of course, they played with the amount of dose and whatnot. So really what we're focusing on is the top row versus the bottom row. Don't worry too much that it replicates in time and to the right. That's just a difference of dosing. And we're not really addressing that question. So no grid, reduced the radiation dose by 26%. That's a win, right? We just reduced our patient dose by 26%. And so historically, we've always said, take the grid out. But the problem was they noticed, and as you could probably see on this lower row, it also reduced the image quality by 26%. In other words, the amount of branching was reduced. You could faithfully see 1 to 2, they could definitely faithfully see 2 branch levels. But the third level was relatively difficult and higher level was pretty much gone. Whereas there is, obviously this is a poor image, it's not magged, it's not on a screen, so I know you can't see it real well. But when you looked at the statistics, and you can go and read this paper if you're really interested, the level of image quality greatly was reduced. So then the question was, and I think this is the point I'm trying to make here, is if image quality, if the type of task you're doing is necessary, then is the reduction of dose appropriate? In this case, the answer would be no. In this case, you should leave the grid in and you should image the body with the grid in. The dose is going to go up a little bit. Now we can talk maybe about ways to reduce the dose in a different way, but for all intents and purposes, for one-to-one relationship here, keeping that grid in would improve the image quality, and that is probably a good thing for these patients. So the old adage of always take the grid out for little kids is not as black and white as it used to be. Now it depends if you're imaging the heart or you're doing something maybe in the kidneys or something, and you need to see really subtle vessel delineation, then the answer is keep the grid in every time. If you're doing maybe some general, you're doing like a VCUG, or you're doing maybe something that's got more gross anatomy imaging, and you're not looking at the fine structures of a vessel, then you can remove the grid, save your patient some dose, and you don't have to worry. But that really comes down to between you, the physician, and of course, the technologist and the medical physicist as you try to optimize that. All right, so we want to reduce the noise. That's the whole point of collimation and grids. We talked a little bit about this idea of new reconstruction techniques coming out. This is kind of the future, and it's still very much being debated. I showed you some images a couple of weeks ago in CT using this new deep learning AI technique where the images, and this is an example of fluoroscopy, noisy image, AI, nice and clean. The noise is basically gone. The structures are still pretty strong. You could probably see all the edges. Whereas if you use a different approach to reducing the noise using spatial temporal filters, which is what we have always done in fluoro, you can see that, yeah, we got rid of the noise. That's a good thing. But the edges aren't as strong and distinct. And so the image itself looks softer or blurrier. AI is promising in the sense that we can probably get rid of the noise and preserve the anatomical structures. Interestingly enough, and I'm not really going to go down this rabbit hole and talk too much about this, but we've been doing a lot of research in this area, and where we thought there was a lot of really interesting applications to AI, we're starting to realize that there are some limitations to that. Imaging anatomy, every day AI makes the image quality looks better because it just removes the noise from a stationary structure. But we're starting to find in other areas where you have subtle physiological, pathological effects going on. So the image itself is not necessarily a normal image. AI has a little ways to go. But like I said, it's an open area that's still being scientifically looked at. And I should say, in fluoroscopy, I didn't point this out, but in fluoroscopy, this is not even an option to purchase at this moment. But having talked to various different vendors and actually seen various different vendors' implementation, as it should be coming out soon, this whole AI thing for fluoroscopy is going to be really amazing. It's going to really reduce the image noise. How impactful it will be clinically is yet to be determined, but it's coming. So I hope you guys all get a chance to play with that soon, because I've had a chance and it's really fun. It's really changing the quality of the images. So I digress. Let's move on. We talked a lot about controlling the noise, so collimating, using grids, or if in some future day we have some fancy reconstruction technique. The next step down along the list of image quality optimization is how we operate the system. Remember, no KV knob, no MA knob, so it's all about how we actually use the system to then affect how our eyes see the image. So one of the most simple ways to improve contrast or resolution is magnification. We've been doing this in fluoroscopy for a very long time. From the inception of fluoroscopy, or at least maybe after the day from the minute we had a system where we didn't have to stare at the X-ray tube, we got rid of those and we had a system that could then magnify the image, and they come in all different distinct or discrete levels. We have had the ability to improve spatial resolution and contrast in an image. So if you have a large detector, a large image intensifier, that's great for imaging large anatomy such as abdomen, whatnot. Small, of course, are used for more niche imaging, such as the heart. We like small because you get better scatter rejection. Now, when it comes to magnification, we have to talk specifically about how magnification is performed on each type of detector. The first is, of course, the II. So here you see a cross-section, a cartoon of what an II would look like. You got the grid on the top. You got the system, as I mentioned, it's in a vacuum, so there's a aluminum structure around it. And then you got your cesium iodide and your photocathode. That's what turns the photons into light and light into electrons. Then you have these anodes here, labeled G1, G2, G3. And these will help steer the electrons down. Not anodes, excuse me, dinodes. And then you have the anode, is where the electrons strike, turns into signal, and we get the signal out. So when we change the amount of the field of view, how much of the area of this input detector we image with, we will change the magnification of the image. The output is the same. It's 2.5 centimeters generally on the back end here. But we can go from as large as 30 to 40 centimeters up here down to maybe a smaller, more focal, centralized, say 15 centimeters. So what does this mean? Well, with an II, this means we get what's called minification gain. And when you do a simple ratio, the area of the input, say 15 or 35, versus the area of the output, which is constant at 2.5, you square that, that ratio gives you the gain. So what are we talking about? When we go from, say, a small 15 field of view, you get a gain of about 36. And then if you go to a medium size, 23, 81, and forgive me, that's a typo, that should be 35. 35 divided by 2.5 squared is 196. So the larger the field of view, input field of view, of course, you get more photons, right? More light. All of that signal gets smashed down to 2.5 centimeters, but the gain is much, much greater. Because we change from large field of view to small field of view, and because the brightness gain changes for each one of these field of views or magnification modes, the problem with that, the con, is that by changing or decreasing or the field of view, so it's smaller, i.e. we're increasing magnification mode, we're decreasing our gain. Therefore, the brightness on the system, the amount of photons collected down here, goes down. And so if you did nothing else but change the mag mode, go from large magnification, large field of view, smaller, 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 the image on your screen in the room would go bright, dark, 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 dark. And so no one would ever use a mag mode because the image would actually be harder. You'd be squinting at it. So to compensate, an II-based fluoroscopic system will increase the radiation dose. Every time you step down the magnification, so you're getting better and better, the radiation output goes higher and higher and higher. This is great for imaging higher resolution. The mag modes, you get better spatial resolution and the smaller field of view, but it's bad for dose. Now, historically, that iris, that output, was fixed at 2.5. In other words, as your gain went up, or as the light went down, your dose had to go up, and it was up by a square. And so when you're talking 20 years ago, or if you have an older system, maybe even 10 years ago, but the older fluoro systems, you go from mag, say 1, 2, and 3, that mag 3 was a high dose because you were squaring that value. Nowadays, the aperture doesn't stay at 2.5. As you start to mag down, so you're going from mag 1, 2, 3, the little teeny 2.5 centimeter iris is actually going to slowly open up. It doesn't get real big, but it gets bigger. Therefore, because we have a dynamic iris aperture control today, what we don't have is the squaring effect to the dose input. Now, dose still goes up. You go from mag 1, 2, 3, whatever, however many mag modes you have. In this system that I measured, we had 4 mag modes. Dose still goes up, but it goes up linearly nowadays, which is a good thing. In the old days, it would go from mag 1, 2, 3, 4, and it would go up here exponential, or it would square. It's polynomial, it's quadratic. So it would actually go up real quick. Now, when you look at the spatial resolution effect, as I mentioned, when you got a large field of view, and then when you go to smaller field of views, you're magging, the spatial resolution improves, and that's a good thing. So the II is listed here as these curves, be it a solid or dashed. There's a slight difference between either a TV or a digital system. Don't worry about that. Either way, the II system improves resolution as you get down to a smaller mag mode, or a higher mag mode, or a smaller field of view. We'll talk about this a little bit more in detail, but the flat panel systems, they do not have mag modes. You can change the field of view. So the image might be big, smaller, smaller, smaller. It's not actually magnifying the image. Well, it does. It has 2 mag modes. It has the ability to bin the image where it's taking, where you have that 1024 by 1024. And so it might take 2 by 2. So you have a 4 pixel square, and it averages all those to be 1 value. So it shrinks your overall matrix by a factor of 2. And so when you're binning the system, here in these larger field of views, you have a lower resolution. When you're not binning those field of views for most of your smaller field of views, you can see you have a higher resolution. So flat panels really only have 2 resolutions. So you can go, if you, for example, go and you transition from a 30 centimeter field of view down to say a 25 centimeter field of view, the image will change resolution. It's obviously smaller, but you will actually physically be able to see a little bit more resolution. Now, if you change from 20 to 15 to 10, your resolution will stay the same. It's a smaller field of view, smaller image. So for whatever reason, if you want to look at a smaller image, go for it. But the resolution itself doesn't change as you go lower. So we talked a little bit about how noise, way back at the beginning, how noise on the II is actually much better than the flat panel. IIs have very little electronic noise because of that gain effect. And so because we are taking the output divided by the input divided by the output, and we're squaring it, we're really tamping down a lot of this noise. The flat panels, because they have to have amplifiers, so all of the electronics that are coming out of the digital, every time you have a pixel or a dexel element, it takes that signal out and you get all 1024 by 1024 signals out. They're all really weak signals because they're just teeny, teeny little dexel elements. They're teeny. And therefore, what we have to do is put a little amplifier, digital amplifier on it. So the signal might be just a little thing. Now it's a big thing. Well, that's great. We get the good signal out, but we also get the noise that's amplified. So everything in the image, noise and anatomy, is amplified. And then we get the reconstructed image. And so to overcome that excess noise, especially in a large 1024 by 1024 field of view, they bin it and they shrink the overall image and they average pixels together. And that is how flat panel detectors try to keep the noise comparable or equivalent to an II system. All right. Now you may say, okay, if the field of view changes, I mean, if the flat panel systems have different field of views, we know that the dose changes linearly with an II. How does the dose change with a flat panel system? So going from a larger field of view, here would be 30, 45 centimeters. In this case, it's listed in inches. As you go towards smaller field of views, the dose will increase slightly. It's not linear, it's not quadratic, it's this kind of awkward increase. So mathematically, it's mostly linear, but it's a very small change. Why does it change? Remember, the actual magnification it really only changes at one point. You see here, it's pretty flat here, and then it starts to increase here. That's where the resolution probably changes because you go from unbinning. The difference, though, is as you make the image bigger, because you're taking a small field of view and you're projecting it onto a large image, the apparent noise or the image becomes more apparent. So the apparent noise enhances. So you actually just can see more noise because the image is bigger. Small field of view enhanced to a big image, you can see the effects of noise. And so in a flat panel system, they actually increase the dose just a little so that you can tamp down some of that noise. So as you make the image bigger and bigger and bigger, the noise doesn't look as overwhelming. Even though if you didn't do that, the noise would stay the same. It just appears different. So it goes back to that whole thing of in fluoroscopy, it's all about the eye, about how we perceive it. So when there's no pixel binning, we need to increase the dose slightly so that we can tamp down or reduce the amount of apparent noise. Dose increases to maintain signal to noise ratio. All right. So when we deal with mag modes, it depends on the type of detector. There is definitely a dose change for the II mag modes, and there is a slight dose change for flat panel. But they're both doing that in order to keep the image quality, the signal to noise ratio, the same as it goes from low mag to high mag. The other way we operate a fluoro unit is the amount of images we acquire per second and then display them in real time. Historically, we would do 30 frames per second over 33 milliseconds. This is the standard if you go to the theater, they go to the cinema, and you watch a movie. On the old reels, where they actually had it all on film, those film reels would roll fast enough so that you would have 30 frames for every 1 second. And that would produce an image that was 33 milliseconds per frame. That's the whole reason we originally started doing this in fluoroscopy back in the 80s and 90s, is because you had the II and you quite literally had a camera on top of it, just like they would have, if you're filming a movie, they had a camera on top of it, and they had film that was cycling through that. And you were quite literally creating a movie. Now, X-ray was on the entire time. You acquired these 30 frames per second, spaced each of them 33 milliseconds per frame, and the effect was a blurry image. Why was it blurry? Because the patient is moving. There's motion. So if there's motion, that motion is being blurred out over 33 milliseconds. And for what it's worth, we can do the exact same imaging, but instead of keeping the X-ray on the entire time, as you can see at the bottom there in that pink fuchsia color, now what we're going to do is we're going to put the exact we're going to acquire the exact same amount of images, 30 frames per second, but this time now we're going to pulse it, and we're only going to do 8 milliseconds per frame. And basically what we're doing is we're sampling the image now. We're sampling it every 8 milliseconds, and we're going to create 30 of those frames, and then we're going to just add them together. And the net effect is when you use pulsed fluoro, you get cleaner, crisper images. So to improve the temporal resolution, not the spatial, the edges, but the temporal resolution, the ability for it to look crisp in time, you actually want to use pulsed fluoro. Continuous fluoro, pulsed fluoro. And it's the same 30 frames per second, but the difference is we're pulsing it. And then you can, of course, do 15 frames and 7.5 and whatever other options you have in your system. Obviously, as you reduce the amount of frames per second, moving away from 30, now you're going to start to see a little bit of a lag in the image because you're not acquiring the same amount of images. So here's just a quick example in real time. I hope there's no lag in as I send my images from Ohio, USA, all the way to Thailand. There might be a little bit of a lag, and my apologies for that. This might look stuttery. But the image on the left is being acquired at 30 pulses per second. You can crisply and distinctly, so the temporal resolution is the same. It is really good. You can read the numbers. You can see these wires. These wires are different thin gauges. Whereas over here, you can still see the wires a little bit, but you really can't read the numbers. They're just being blurred out because that motion is being collected over 33 milliseconds. So temporal resolution. Our eyes are absolutely amazing. Our human eye has a natural lag of 0.2 seconds. So with 30 frames per second, that means we can collect 6 frames and we average those together. That's how quick our eyes can go. And that's a wonderful thing. So that means for every 6 frames, we put that together as one in our brain. And so therefore the perceived noise goes down. We're averaging. Our brain is actually doing a filter. And it reduces the amount of noise that we see because we can perceive, we can collect images very quickly in our eyes. 6 frames are averaged together. So noise perception is reduced with reduced pulse rate. So if you're just simply giving, instead of 30 frames per second, where every 6 of them are averaged together, now what happens if you're only collecting 6 frames per second? or 5 frames per second. Well, obviously the brain's not averaging anymore. It can't. There's just not enough signal coming fast enough for your brain to put them all together, average them together, and process the next one. So as you reduce it, going from 30 to 15 to 7.5 or whatever it is, as you get closer and closer to this magic 6 number, the amount of noise in the image increases. The perceived noise will look more, and it'll look more noisy in the image. So we need to compensate by increasing the amount of dose per pulse as we go from 30 to 15 and lower and lower and lower. This is called, it's called the Fichte principle. So, sorry, I had one more point I needed to say. We've done different studies. A lot of people have looked at this. We personally have talked to a lot of our interventional radiologists and cardiologists about this. And when it comes down to low pulse rates, people have often said, I can't use a low pulse rate to do my fluoro procedure because it's not because of the low temporal resolution, the choppiness of it, the slowness that the images are presented on the monitor. It's the noise that prevents them from seeing what they need to see. And so what we want to do is we want to reduce the amount of pulses per second, because it obviously reduces the amount of dose to the patient. If you're only putting in 7 pulses versus 15 versus 30, you're obviously reducing the amount of dose to our patient. But if as you reduce the numbers of pulses, i.e. the dose, and the image quality goes poorly, then you've done no good, and the doctors will not be able to use that, and therefore you're actually not saving dose to the patient. So when you look at it mathematically, if you have continuous fluoro over 33 milliseconds, so you have this area on this graph, we want to keep this area the same when we pulse it. So if we acquire same amount of photons in that 33 milliseconds, but now we acquire that same amount of photons in only 8 milliseconds, well, that's great. Now the noise will be perceived as the same. Now what happens if we are quite literally skipping every other one by doing 15 pulses per second? Now our eye is not being able to average as much, so we need to take each one of these values and we need to make them taller. We need to collect more dose per pulse if we're going to reduce the amount of pulses that we see in the image. Now, this will benefit us in real time as the images are presented, as your foot is on the pedal. But the other thing, and I'm going to talk about this, I'll show some images at the very end or in a couple of slides. But the other thing this really truly affects is the last image hold. So we talk about dose reduction. We'll talk about it next week. But we talk about dose reduction being time. If you reduce the amount of times you're stepping on the pedal acquiring images, you're reducing the amount of photons you're putting into your patient. Well, that relies on the fact that you have a couple of different tools to work with, one of which is a last image hold. So you let off that pedal, and the last image that you just acquired would be presented there in the room. And so you could look at the image as a physician, and you can decide if you want to do this or that, or change your trajectory, or hey, maybe we need to manipulate the patient. You use that as a way to think forward, think on your next step. What do I do? If you didn't have that last image hold, you'd have to quite literally just put your foot on the pedal and do the exact same contemplation, which just means more dose to the patient. Now, if that last image hold up there just looks crummy, how can you plan for the future if the image's quality is so low? If that's the case, most doctors would just keep their foot on the pedal and keep presenting. So you're going to find that we need to get the right dose to the detector for each pulse, so the image quality looks good in real time. And so when the last image is presented, the image quality statically also looks good. So let's talk a little bit about this. Actually, not talk about it. Let's present a couple of examples. Here's a watch. And the next couple of slides, I'm going to show them to you in real time. So all the gears are going to be moving. So just look at the overall noise as you go through this. There are a couple of areas of uniform background. If you want to really just focus in your eyes on that area, that might help you with your ability to see the noise. And once again, I really truly hope this kind of presents to you really well. Actually, what I'll do is I'll optimize for video clip. Hopefully that might help a little bit. So this is moving, the one on the left is moving at 30 pulses per second. And this one is moving at 7.5 pulses per second. Obviously there's a little bit of a lag. You can kind of see the gears are a little blurred out because the gears are obviously moving fast enough. Now, if you see this word dose and the letter X next to it, that means this is getting X amount of dose and this is getting the same X amount of dose. Same dose, but 7.5 pulses per second means that there is actually a dose reduction of factor 4. So you're only getting 7.5 frames for the same 30 that you would get. But if you look at the noise content, maybe focusing here on that uniform area, that is a probably noisier image on the right. You may think that's noisier. In theory, it should appear noisier to your eyes if the image is coming across the video. So, all right, already we have a 4.5 times dose reduction of the patient. That's a good thing. But what if we put some dose back? What if we increase the dose by a factor of 2 to the image on the right? So now, still 30 pulses per second and 7.5 pulses per second. I hope now you can see that the image quality on the right, i.e. the noise, the amount of noise in the image has improved. And this patient on the right still would receive a 2 times dose reduction. Not 4, but still dose reduction. And the image quality, I would argue, is as good or maybe a hair better than the one on the left. You still have the same temporal lag issues because this is 7.5 pulses per second. But what we've seen is, as we've talked to radiologists, that where they were historically unable to do anything other than 30 or 15 frames per second, now they can habitually use 7.5 or even lower pulses per second, not because of necessarily the temporal issue, but because the images now look as good a quality as the 30 pulses per second because of the noise. All right, so that is the Afrique principle. My colleague and friend named Keith Strauss added to that. I call it the Keith Strauss rule. And that is, we talked about this idea that our eyes can integrate 1,000 frames per second, and just, you know, some statistics here, the myelinated nerves can send images, 300 to, not images, excuse me, signals, 300 to 1,000 signals per second, which is pretty darn quick. That's 320 kilometers per hour. Our brains, our bodies are just amazing. But what that basically means, as I've mentioned, is that means we can integrate, we can average 6 frames per second. If you go below this value, so once you get to 7.5 pulses per second, so from 30 to 15, we've increased the dose per pulse. 15 to 7.5, we've increased the dose per pulse. But it doesn't make sense to keep changing that dose, because after you get at 6 or lower, your eye does not integrate that. Therefore, the dose, the perceived noise will be the same at 6 frames, 4 frames, 3 frames, 2 frames, 1 frame. The noise will be the same in the image. Obviously, it's coming at you more, there's more of a lag, it's more choppy because you're doing less frames or pulses per second. But the noise is the same. So let's look at that. 1 pulse per second on the left, 7.5 pulses per second on the right. Noise content is the same. It's perceived the same, and it is physically the same. But the patient on the left got a 7.5 times dose reduction. So if the temporal aspect of this image is not that important to you as a physician, then let's go for the dose reduction. And in a real world example, our physicians, when they're doing line placement, really simple stuff, almost always our physicians use 1, at most 3 pulses per second. And it's because it's meant to be a low dose, very simple procedure. They can advance the lines, they can do whatever they need to. The image quality is comparable enough so that they can see the line inside of the anatomy and they can go forward. So let me turn that off and get back over here. Okay. So what we need to do to get good image quality, good noise control, it starts before the first patient even walks into the room. The medical physicist needs to work with the system. They need to measure the amount of radiation dose at the detector, that EERD, the entrance exposure rate to the detector. And they need to make sure it's comparable as they go from 30, 15, 7.5. And once they get to about 7.5, 6, they need to make sure it's the same thereafter. And that will make sure the noise and the contrast to noise and the signal to noise, all of these metrics we've been talking about, will all be optimized. Now, let's put this all together. The AERC, the auto exposure rate control. We don't have the knobs to twist. The system does this all automatically. So how does the system do it? The IAEA put together this nice little infographic. So I'm going to refer to this. There are some fundamental principles that we always need to know and account for to create an image. We need to know, and I'll explain each of these as we go forward. KV and MA, you're very familiar with. That's just the X-ray tube creating photons, X-rays, as they come out. We need to adjust the KV and the MA. We always have some type of filtration. Remember, we want to get rid of the low energy photons. That's just to get absorbed on the skin. They're not used for image quality at all. All they do is dose our patients. So we always put filters in there to reduce that. In CT, we call them bow tie filters. Going forward for fluoro, X-ray, and mammography, we use very specific types, and we'll talk about that in a second. And then, of course, there's the focal spot size. That's in the X-ray tube. The smaller the focal spot size, the better the spatial resolution. That was the same for CT as it is for fluoro. And then there's this thing unique, of course, to fluoroscopy, which is the pulse width. So if we're going to pulse it, if we're going to send in one pulse after another, the idea is you want to keep them as short as possible. Up to this point, I've given you the example of 8 milliseconds. So we've condensed our 33 milliseconds down to 8. In reality, what we want to do is there are different types of pulse widths that we can control. The way the system works with the AERC is it's always going to default. So it's got the small to large patient continuum. You can see how as we go from a small patient to a large patient, how each of these parameters changes. Some go up, KV, MA, pulse width, they all increase. Well, actually focal spot size too. Some decrease, which is the amount of filtration. The system will always try to do the shortest pulse width possible, which gives a very sharp image, the smallest focal spot size, which will give a good resolution, sharp image, the largest filter as possible, which gives low patient dose, the lowest MA and the lowest KV, which low patient dose, and I might add low KV equals high contrast. Obviously, we don't control this. It's the type of patient that we're imaging, very small to very large. Typically, if you look at these plots here, MA will be the first variable to change. So if you have a patient that's typically small, but now there's obviously going to be very, very small and not so very small. Obviously, there's a continuum of sizes here. So in this case, the KV will be constant, the filtration, the focal spot, the pulse width will all be constant, but the MA will change over that continuum. And MA will always ramp up as high as it can, trying to keep everything else constant. Because if we absolutely have to change anything, the next time we change things, the MA will come down, but the KV will come up. Okay, so if the KV went up, contrast changed in the image. If the focal spot has to get bigger, resolution changed in the image. If the pulse width goes up, resolution changes. If the filtration changes, there are some effects on resolution and all that other things, but obviously patient dose changes. So the MA is typically the first thing to change. And then what we're doing, the system is trying to do, is to keep the same KV, so the contrast is the same, at the lowest value possible. Oops, excuse me. So let's start talking about each one of these. Pulse width. Pulse width equals exposure time per image frame. Long pulse widths capture more motion. Remember, olden days, we had 33 milliseconds. When you had a beam on time for 33 milliseconds, all of the motion that occurred in 33 milliseconds was blurred or averaged together. So the goal is to shrink that, to keep that as short as possible. And as we shrink that, we also have to make sure we keep the right amount of photons onto the detector. So we squeeze it down, but that also makes it so that the overall magnitude will increase, right? If we shrink it down, we make it short, we go from 33 to 8 to 5 or whatever, but we don't make the magnitude go up, then the image would be really noisy. So this becomes a physical limitation of the system. How many photons can you put out, can you get out of the X-ray tube into the detector in the shortest amount of time? All right. The typical values that, at least as a medical physicist, I always try to get when I sit down and I work with when we buy a piece of equipment and I sit down and I work with each of the vendors, some vendors you can actually make these adjustments. Other vendors, there is no chance. But I sit down to them and I say, for the smallest patients, I want a roughly 5 millisecond pulse width. In a perfect world, for you and I, for most of our typical size adults, I wouldn't want more than 10. Now that's kind of a pipe dream sometimes. Most of the time they look at me going, oh, we can't do that. And then for bariatrics, just because the bigger they are, the more photons you have to push through, therefore the higher that pulse width has to be. Therefore, there's just a limit to how high it can be. So therefore it has to start to expand out again. So for bariatrics, it would be somewhere closer to 20 milliseconds. If you go in and measure this for all of your different systems, I'll bet you right now, every one of your systems are different. So you take the same, for example, block of plastic. Let's say you take 15, 20 inches or centimeters of plastic. You go put it in your X-ray tube between the tube and the detector, and you image it, and you put your solid state detector in there, and it'll measure the waveform. A lot of the mobile C-arm systems are somewhere in the 20 to 30 millisecond range. Some of them are no better than they were in the olden days. They're a little better, but not that much better. And so we're constantly telling them to turn that down, turn that down. Your more high-end interventional systems will have these values down closer to 5 and 10. And the same for your general fluoroscopy, your table tilt systems. But this is just a rule of thumb, but this is what I typically always tell them to do. I want as short as possible for the smallest patients. And why is that? Well, that's because there is a lot of involuntary motion that happens inside our body, especially if we're imaging in the thorax or maybe the upper abdomen. As that motion moves, and if it's moving over 5 milliseconds, it's being averaged together. There is nothing you can do as a physicist, as a physician, as a technologist to prevent that. Say turning off their lungs and turning off their heart. Just nothing you can do. So if we can image quickly, we're minimizing that blur. So obviously 5, 10, 15, 20, 30 milliseconds, the image just gets blurrier and blurrier and blurrier. So short pulse widths. What does that look like? Here, let me optimize my images again. Okay. Optimize. Okay, I just turned zoom on to optimize. Oops. There we go. Turn this back on. Hopefully it's coming across real well. The ones you see on the left, This is acquired at 30 pulses per second. It's been displayed, so it's been resampled to 7.5 pulses per second with a 2.5 millisecond pulse width. Everything's the same except for on the right, it's a 7.5 milliseconds. So these are short pulse widths. Each one of these wires is a different gauge, different French gauge, 3, 4, 5. Over here, you could probably see 3 and 4. You may be able to see the ghosting of 5, probably definitely not 6. But over here, definitely 5 is visible, at least in my eyes. And hopefully it's coming across video-wise to you. The 5 is visible. So you want short pulse widths if the for example, the anatomy, the arteries that you're imaging, say you're imaging the arteries of the heart and they're pulsing, they're moving, and it's a little kid, you got really, really, really small arteries, then you need to get that pulse width as low as possible. So even though it's moving, you can still collect that and it's not blurred out to the point where it just disappears as it does here on the right-hand side. All right. The other thing we want to do is grid control. And this is something you just buy. It's either a reality for your system or not. There's no real button you push that turns on grid control. So when you go to buy a new fluoro system, ask, do you have grid controlled pulse fluoroscopy? What does that mean? Well, for every pulse that we acquire, there's usually a ramp up to get from the right amount of temperature on the cathode before the electrons will boil off, accelerated until they hit the target or the anode in the X-ray tube, and then they create the image. Well, they create the X-rays that come out. Well, because there's that heating and deheating and heating or cooling, heating and cooling, heating and cooling, and so you're pulsing out the signals, you have these tails. Those tails create different energy photons that are in no way, shape, or form good for imaging the body. They're a necessary evil because you have to create them. You just have to have it so the system will turn on to create the X-rays. But a lot of the new modern systems will have what's called a grid control, where the actual cathode, when you're imaging, when you turn on the system, the cathode will turn on and stay on. And so there's actually electrons boiling off constantly, but they have various different magnets and other ways to keep the electrons at the cathode side. So you basically have a magnet shielding the electrons from leaving the cathode. And then the minute you step on the pedal, it will snap off. And so the electrons go and then it'll snap back on, snap off, snap on, snap off. And it's the grid, that's the pulsing. And so it's able to create more of a distinct edge and you don't have these tail effects. So it actually effectively shortens the pulse width. It removes excess dose to the patient. And it's better for the overall image quality. All right, so the other thing was the filtration. So let's take a step down, we had filtration. Most systems use copper. That's just standard. Others may use aluminum or some combination of the two. Oftentimes they use copper because it's just a higher atomic number. Therefore, it's really good at absorbing low energy photons. Some systems, like Shimatsu's and Canon, they use rather exotic elements such as gold or tantalum. And that's just different atomic numbers. And so it's a way to enhance the attenuation with smaller amounts or thinner amounts of filtration. You can get filtration from as short as 0.1, 0.2, 0.3 millimeters of, say, copper or gold or tantalum, all the way up to 0.9. And if you're using 0.9 millimeters of copper, you're very aggressively reducing the amount of photons. Therefore, your pulse width cannot be short. It has to be wide. There's just no way to get enough photons out through a 0.9 millimeter thick copper filter. And so to overcome some of that, that's why some of these like Shimatsu and Canon, they'll use the gold and tantalum and whatnot because it's a higher atomic number, so it doesn't need to be as thick. So in that case, it might only be 0.1, 0.2 millimeters. And you get the same net effect of, say, a 0.9 millimeter. So your pulse widths can stay shorter, and therefore resolution stays better. All right, overall spectral filtration, as I've already mentioned, is good for reducing skin dose, gets rid of all those soft soft x-rays, low energy x-rays. The consequences, as I've now mentioned multiple times, require higher MA to pass through. Therefore, it requires a larger focal spot and larger pulse width. So it reduces spatial resolution. The thicker the filter, the lower the spatial resolution will be, the lower quality the spatial resolution will be. So how does the system pick which filter to use for the size of patient? There are two ways. And once again, this is dependent on the type of machine you buy. The filter, the vendor or manufacturer makes this choice. This is not your choice. So you can just ask them. And it's not necessarily I'll show you the differences, but the approaches are just slightly different. I would argue the image quality on both sides of all machines are basically comparable today, modern day fluoroscopy. So the first approach is what's called anatomical program-based filter selection. So you, the physician, you walk in, you're doing a VCUG or something on a table two, or you're an interventionalist and you're going to do something. So you push the button on the machine and you pick the anatomical program. So if it's a VCUG, it's a VCUG. If it's a video swallow, we're going to do a VCSS or whatever we're doing. We just push that button. And when you tell the system what kind of anatomical imaging you intend to do, it has in its little computer brain, it's already picked out which filter, so it's going to be 0.1, 0.2, 0.3 millimeters of copper. It picks the right filter. And it will then have these curves built into it. So because it's a single filter, the entire time you're imaging, it will change the two potential KV and the MA in a very specific way. Some of it may be linear. Therefore, as MA changes, as it increases, so does KV. Others, as you can see here, the KV will change first, and then the MA will change with some KV. And in this case, the MA will change very strongly, very aggressively. Excuse me, KV will change very aggressively. MA will hardly change at all. And there will come a point where you just max out the MA. So the MA has to reduce as you increase your KV even higher. So there's always some way these systems approach it. But for the anatomical programmed-based filter selection, it's the same filter through the entire imaging chain. Then there's the Cecil method. And this was named after Siemens engineer John Cecil. Now you can imagine, obviously, Siemens uses this technique. Other vendors such as GE also use this technique. Now, the MA and the KV change along with the filtration. So now you look at these plots and they look all crazy. In other words, you can see here, for example, that there are 0.9, 0.6, 0.3, 0.2 millimeters of copper. So if you look at the different markers, they're different sizes. So you might start here, this hollow square, which is 0.2. Excuse me. You might start with a low amount of filter at a high MA, high KV. And depending on the size of the patient, it'll change. But at some point, it's going to switch and it's going to go over here and it's going to change filter. So it might go from 0.2 to 0.3. And then 0.3 will work over a short range of MAs and KVs. And eventually it'll then change again. It might go up to a 0.6 and 0.9. So it just depends on the size of patient and the requirement to get the right dose to the detector. The filter selection, KV and MA, will change quite drastically. There is a lot on this slide. The reason I'm showing you these 4 plots is to give you one point. If you look at this top left corner, here basically you have these simulated patient thicknesses. All they are different thicknesses of PMMA of plastic. As physicists, we love to use these plastic blocks because they give a good, reasonable approximation of how patients will change in thickness. Now, look at these. There's a couple of different vendors presented here and the different ways that they change their amount of filtration, amount of KV, and amount of MA in the image. No matter how they make all of these changes, based on patient thickness, look at the output. The air kerma per minute, so the dose rate, is pretty consistent over patient thickness. So the take-home message is it's good to know how your system operates, because if you come over here and let's just look at this plot up in the upper right-hand corner, this plot, you have a couple of different systems, a couple different vendors. So if you have vendor in the orange, vendor A, they use 0.1 millimeters of copper, irrespective of how thick the patient is. So that's static. Therefore, KV has to change. So when the patient starts to get a little thicker, you go from a low KV to a moderate KV up to 80 KV. And at that point, you can see here at roughly 15, you come over to MA, you see the MA starts to ramp up really quick. And you get to a point upwards of 35 where MA just can't go any higher. So now the KV has to start to come up. And so you can see their approach, even though their dose rate is basically the same as everyone else's, they will change their KV slightly differently and their MA differently. This system, because it has a 0.1 millimeter copper filter, is going to allow you to have short pulse widths. So the contrast in this system will be slightly different because it's the KV changes slightly differently. But the resolution of this system will be probably different compared to this guy, system C, that has this X, blue X, this blue X. So they start off with small patients. They're using 0.9 millimeters of copper. So great dose reduction for the patient, lower spatial resolution potential for this patient. Because they have such thick filters initially, they do not have to aggressively change the KV at first. So the resolution will be lower, but the contrast will be more constant over this range of patients or this range of patient thickness. So if you're going from maybe a thicker abdomen or a thinner abdomen to the pelvis, etc., however that attenuation profile changes, this X is pretty consistent. It doesn't really change that much. It's not as aggressive. And so by the point where the system one, this A, was 80 kV from 10 centimeters all the way out to 35 centimeters, this blue X system really doesn't even get to 80 kV until the patient's relatively large. So because you use larger filters, they're able to do a more consistently low KV. Therefore, the contrast is going to be just much more intense. So my point here is you got to know your system. You need to know if your system is going to be, or potentially if a system you're going to buy, if you're doing all cardiac imaging in a pediatric center and you got to see these teeny, teeny little vessels and it's going to be moving like crazy, I personally would not purchase System C at this high filter. Or if you buy System C, you're going to have to talk them down and see if they were willing to change their programming to allow lower filters at the smaller patient sizes. So once again, the way image quality works is how we use the system. So I put this slide back here just to remind you once again, every one of these 5 parameters will change based on the AERC, and it's not based on you, it's based on the patient. So the user really can't control this. So you need to optimize the system before the first patient ever sits down on your scanner or lays down on the table. All right, we talked a little bit about so up to this point, everything's been dynamic. It's been in time, temporal imaging. And we have a couple of options for dose reduction. We'll talk more about this next week, but this idea of last image hold, where you've been acquiring, and then you let off your foot. Now you're just looking at the image. As long as you have put the right dose per pulse, so you go from 30, 15, 7.5, you've increased the dose per pulse, that last image hold will actually look okay. So you'll be okay. You just keep going. You your last image hold will look good, and so will your temporal excuse me, your temporally acquired images will look good. And this means you can do other things that are helpful for dose reduction and actual imaging, such as road mapping, or you take those last image holds and they can be displayed as you do, dose mapping with like your angiographic imaging, where you're really just trying to make the vessels pop. So there's all these really cool ways to image in using fluoroscopic systems, but you got to get the right dose per image so that each one of these tools you use will look good to the eye. So let's give a quick example. All right, so if you have the last image holds, because our eyes are filtering, every 6 frames per second, our eyes are filtering, the MAS, the dose per pulse, or the dose per image that we get, will actually be much lower as we perceive it than our typical static image. So in the X-ray room, when you just take one image of a PA chest or a AP chest, the image will actually look a little bit more noisy in that static image than if you are acquiring that image in time because of our eyes. So what we need to do is we need to make sure the dose per pulse is higher so that when we do that last image hold, as I mentioned, the dose is okay. All right. And then this is an example. There it is, right there. Sorry. This is what I'm trying to get to. So last image hold, you can kind of see here. There are different ways to make this last image hold look nice. Historically, we did what was called recursive filtration, but that led to this blurring. In other words, the minute you stepped off that filter, that pedal, the last image hold was actually an average of 2, maybe 3 or 4 of the last frames just averaged together. But because there's motion, because we're doing this in time, those edges will get a little bit blurry. But if you acquire this with the right dose per pulse, that last image hold won't have to be the last 2 or 3 or 4 images averaged together. It could quite literally be just the last 1 or 2 images, and the image will look a lot more crisp because it's the dose per pulse, not the averaging that's creating that image. All right, and so one of the last things we need to talk about is, as we mentioned, how you use the machine also directly affects the image quality. So if you got a image intensifier or a flat panel detector, you're standing at the table and you're operating it, if it is elevated or away from the patient, you are using what's called a bad geometry. Well, what's the problem with that? Well, the farther away from the patient that is, the more scatter or the more radiation coming off the patient will be collected by the detector. Therefore, when you consider contrast to noise ratio, contrast divided by noise, that ratio, if noise gets higher because of scatter, the overall CNR goes down. Contrast is the same, but noise is higher. The contrast to noise ratio goes lower. So the best thing we do is we place that detector as close to the patient as possible. Obviously, you might need to be manipulating and working with the patient. So if the detector is too close, obviously there's a give and take is what I'm trying to say here. But the lower and closer to the body that detector is, the better the image quality, always. We'll talk about this next week, but there's also a dose penalty for this. These detectors will tell the system to run the radiation, to produce more radiation the farther away they're pulled, because there is a point 30 centimeters away from the detector that is where the system is measuring how much radiation is coming out. And so the farther away from the X-ray tube it gets, the more the X-ray tube thinks it needs more radiation. But we'll go into detail about that next week. So best thing to do for image quality and patient dose is get that detector as close to the body as you can. The other thing that is really good is the closer this is to the body, the better the resolution. And we'll talk about this especially in X-ray and mammography, when you take an object and you move it away from the detector, you get what's called a penumbral effect, or you get this blurring, geometric blurring around the edges. The closer you put the object to the detector, the crisper that image will look. So not only does the contrast improve in this geometry, but so does the spatial resolution. All right, so let's summarize kind of what we've been talking about. The benefits of flat panel, and let's compare them to an II imager. So the flat panel detectors have pretty uniform response across the field of view. We didn't really talk about this in the past, so I guess it's not much of a summary point, but the idea is that there are some artifacts inherent to II. There is geometric artifacts and light distortion. Whoops, and my animation's all wrong. Sorry about that. So there are artifacts with respect to II that you do not get in flat panel. And so let's talk about those artifacts real quick. So there's the veiling glare. Remember, there is that dynamic range effect that you get on an II that you do not get in a flat panel. So if you're imaging and hopefully you would put collimation, maybe they're doing a VSS, doing a video swallow. So really all you need to see is this area so you can put your collimators in. But there would still probably be a little bit of air around the neck that would be present. And so you will pretty much always have some kind of veiling glare or just this bright light that appears to your eye that will wash out the contrast in the rest of the image. And then you have what's called vignetting. And that is you just have a stronger signal, brighter signal at the center than you do at the edges. And that's because the II, as you remember from the diagram, the actual input surface is curved. It has to be curved because it's got a vacuum. So the physical structure there's no air inside there. And to get the air out, you have to have a vacuum on it. If you have a flat surface, it would actually bow down. So engineering wise, you have to put it on a curve, and that structurally makes it strong enough to put a strong vacuum in there. But because you put a curve on your detector, you get this effect. You get the vignetting, where your signal is the strongest in the center, weakest at the edge, but then you also get this blur, you get this distortion, a pincushion distortion or a barrel distortion. And so when you place a structure in it, it'll either kind of cave in or bow out. And because these systems, because you're quite literally creating electrons that are accelerated down to the anode. If there's any kind of magnetic field, obviously electrons are negatively charged, they will be affected by magnets. So if for whatever reason you built a fluoro suite next to an MR suite, and it's an II, you would probably see this S curve, this distortion. This distortion is from the electrons being deflected because of a magnetic field. Nonetheless, these barreled, pincushion, S distortion, the vignetting from the previous slide, and the glare effect, those things you do not really get in the flat panel detectors. Flat panel detectors are strong in that regard. They do not have a lot of artifacts. Flat panel detectors are also good ergonometrically because they're just small. So if you put them closer to the patient, you can still get your arms around and operate. You can still usually do whatever you need to as a radiologist. And they do have pretty good spatial resolution comparatively compared to an II. That said, the II has the ability to mag better. A flat panel cannot mag the same way as an II. So that's just a trade-off. Inherently, the flat panel detector has better image spatial resolution, but it only really has two options. One, then from binning, and then when you change to no binning, you get the other. The II strength comes with its noise handling because of that gain correction, or not correction, but that gain magnification. You get really good noise control, especially at the low dose levels. So there comes a point where you keep lowering the dose on a flat panel system, and we'll talk about this next week, but you get to the point where if you get too low, the image is just going to be noisy, and there's nothing you can do about it. You can't bin anymore. You don't want to bin because of spatial resolution. But because of the II detector's brightness gain, they are really good at imaging at really, really low doses. All right, so that's kind of a whirlwind. We talked about the three main features we're trying to optimize for image quality: spatial resolution, low contrast optimization, and noise. And we just talked about all of the different ways the Fluoro system creates an image and how they will directly affect these three optimization parameters. And I think the overall take-home message is, when you're sitting or standing table side operating the system, there's actually not a lot you can do to optimize your image quality. Most of your image quality is optimized before the patient walks into the room. And that is a collaborative effort between the medical physicist and the radiologist and technologist. They have the opportunity. We kind of talked about this teamwork effect a couple of weeks ago, that we all work together. And in this case, it's also probably a very good relation. You need to have a good relationship with the vendor. When you purchase the equipment, you have your field service engineer that will come in and periodically do their periodic maintenance or their PM testing, not testing, but corrections. If you have a good relationship with them, then you can sit down with them and say, hey, I want the shortest pulse width possible. And they can help you dial it in if possible. And then you can say, hey, I don't want overly aggressive filters for my little kids, because I want to be able to get good, small, short pulse widths, et cetera, et cetera, et cetera, et cetera. So I'm not going to rehash everything, but it has a lot to do with those good relationships between the technical side and then, of course, the clinical side, because ultimately we want to make the right image, have the right image quality at the right dose for our physician colleagues, for our radiologists, so that they're happy and they can do the job they need to, which is to help our patients. So that's everything. I'll turn the time back to you, Tanya.
Thank you so much, Sam. There is a lot of data and factors about the physics that I need time to digest. So too many details for today. But you know what? We have a good questions from the chat box. So this is a very nice talk and very good idea to use the PMMA lab to demonstrate the characteristic of the system. This makes a good understanding of the behavior, how our machine or system change and adjust their parameter when the patient size is changing. So the question is how we implement this experimental data, PMMA thickness, into the clinical practice in terms of like a different patient size to define the protocol for pediatric or obese patient. For different body examination part, should we correct the patient's data along with the experimental data to be used for the protocol optimization? If yes, how we analyze this data?
Sure. That's a great question. And actually, that's probably a very big oversight on my part. I should have probably demonstrated. I will maybe put another slide on next week, but right now I am pulling up a Excel spreadsheet for 1 second.
And I believe the person who asked this question is a medical physicist.
I love medical physicists. It's a great question. It really is.
Oh, yes.
So how do you use the PMMAs? What order? And how much PMMA do we use to approximate a patient? So where did my... Here we go. All right. Hopefully you can see my screen now again. So this is an example of a spreadsheet that I created, and this is one of the ways I test our system. This is actually a general fluoro unit. Here's, you can kind of see on the right-hand side, an image. There's the table. Here's it's actually an II system. So the II would be up here. I have these little blocks right here, so I can place my detector right directly on the table. I do that on the table as we talk next week, because that's just where the system has its reference point for radiation output. We'll talk about that in depth next week. But that's the reason I I place these blocks here so I can get my detector under there. And now you have all of these various different thicknesses of PMMA. And those phantoms, this is just kind of what I look at. So I have 5, 10, 15, 20, 25, 30, and then I will actually put a lead block on the top just to make the system go as high as it possibly can, just to check the maximum output. And then I check the fluoro system, so the just fluoro, and then I look at the digital image. So you got the acquisition image or the fluoro spot, the spot image, and then just the regular fluoro. And you can kind of see how it changes. I write down the KV values and the MA values, and I check them with time. So every year to make sure they're all the same. But you can see this system as it goes from thinner to thicker, how the KV ramps up pretty quickly. And the MA doesn't quite change as much aggressively. It does go higher, but this system, it really adjusts the KV. And to let you know, this system uses one filter. It's 0.1 millimeters copper the whole time. But then as I look at the different mag modes, that's what I'm magging from 31 to 25 to 20 down to 17. So this is the highest mag mode. You can see how the KVs will then change in MA. So I look at this as a function of this. So then the other question you're asking is, in what way do they relate to patients? So let me take you back. This is a paper that's actually going to be published really soon. Oh, sorry, I'm in the wrong folder. And so I'm more than happy to send this off as soon as it gets published. And if not, at least I can get this. For those of you that have AAPM memberships, you'll be able to get this without any issues. All right, where are you? Fluoroscopy. I just got to remember where I put it. So let's pull this up. So now we're going to look at right here. I don't think this is what I wanted to show. All right. Well, I am sorry. I have a chart that will tell you how thick each one of these slabs are and what they compare to. Like, so, 5 centimeters is obviously going to be like an arm, an extremity. 10 centimeters, now you're talking like a little baby. And so I have a chart. I can't quite remember where I put it. So I will make sure to put that on first thing next week when we talk doses. So you'll be able to say, hey, if I want to go in and I want to optimize for an adult, then you probably need, say, 20, 25, 30 centimeters of plastic. So I'll put that in. But here you can see this is just another where I have my interventional system. And once again, I've got my blocks. And now because the geometry is different, I had to actually test it both laterally, because obviously you can use the system laterally. And I had to test the system in the anterior posterior through the table. So these blocks are pretty handy. You can kind of do all crazy stuff with it. So I will get that, and my apologies, I really should have included that in this talk, but I will put that in next week.
That's okay. So next week we can talk more about this thing.
Yeah, but each block thickness really does approximate a rough thickness of a body. Now, this is, in all fairness, it's mostly for abdomen. Obviously, when you get to the chest, you got air, so it's a little different. We've had to come up with different ways to make an equivalent chest phantom, but I'll talk about that also next time.
Sure. So the second question is about the continuous fluoroscopic mode. So according to your talk, seems like this is not a good mode to use for the fluoroscopy because of high dose and poor image quality. So the question is like, do we still have that continuous mode in the machine, and what is the indication? Because I remember in the past I used that for looking for the diaphragm movement in children, looking for maybe like a foreign body aspiration or obstruction, and see the movement of the diaphragm.
Yep. And so movement, yeah, if you're okay with a little bit of blur, it's okay. So I'm going to tell you a little dirty secret that most places, there are some systems that you buy that it'll have a continuous button. Very specifically, there's one vendor, one mobile C-arm. I have no issues. It's GE. Actually, they're not. It's OEC, but GE owns OEC, so it's basically a GE system. So if you buy their system and you look at their little control unit, there's a button that says continuous and the one that says pulsed. When you push on continuous, it's actually not true continuous. It's actually 30 frames per second. It's actually 30 pulses per second. So the dirty secret is it's not true continuous. True continuous is actually kind of hard to find nowadays. If you have mostly modern equipment, I bet you do not have continuous options anymore. You have 30 pulses per second or anything lower than that, say 15 or 7.5. And so everything I showed you, this whole idea of continuous 33 milliseconds, that's actually, unless you have an old system, you don't have that option. If you have an older system and it says continuous on it, you need to verify that it is not 33 milliseconds. The way you test that, well, first of all, maybe the manual will tell you what it is, so you could just read it or you can ask the vendor. But if you don't have the ability to do that because you don't have the manual or the vendor doesn't know, the field service engineer doesn't know, if you take your what's the word? You take your detector diode and you put that in the system and you turn it on, it will measure the pulse width out. And with that pulse width, you'll be able to see, I don't know if this will show, but you'll actually be able to see and measure the width of the beam. I'm going to open this up and see if it still has my pulse widths collected on this data. And so yes, you don't want to use continuous, and you as a physicist and a technologist actually have the ability to go into the system and set it so that when the radiologist walks up and clicks, say, VCUG, or they click, abdomen or whatever for an interventional procedure, when they look down at their system, the table side or the bedside, they will have several options. Maybe 3, maybe 4 predefined pulse levels. It might be 30, it might be 15, it might be 7.5. And so those options will all be available to the radiologist or the interventionalist. And then it'll always default to 1. So as an example, we will always default ours to, say, 7.5. So it starts low. So the first thing the radiologist will do is they'll walk in and they'll start imaging and they'll go, okay, I can't really see. I need a little bit more. So when they push the next button, the next highest button, it'll go to, say, 15 or maybe 30 or whatever it is that we need to do. Each anatomical location is a little bit different. So you have an option for each one of them. But the point is you're able to help predefine the parameters so the radiologist doesn't have to think. All the radiologists should think about when they walk in that door and they start working with the patient is, oh, if I need a little bit more, I just push this button. I either mag down or I increase my pulse rate. And hopefully those are really kind of the few options they have to think about. They're not going to think about filters. They're not going to be thinking about the KV, the MA, the pulse width. They're not going to be thinking about that. Hopefully you have optimized that as a physicist or a technologist beforehand.
Should it be like a preset stuff?
I'm sorry, say that again?
Should it be like a default or like a preset setting on those things for radiologists? Mm-hmm.
Yeah, all of those things you can predefine on a system. Even if you've bought the system, you can go in. There's always going to be a service mode or an admin mode. Mm-hmm. And there should be someone in your department, usually a technologist, that is the lead technologist. So they will have that passcode and you can get in and you can see, and there's so many options. And so I always recommend that you work with your app specialists for, let's say you have a Philips unit or a Canon Toshiba unit. You would say, hey, I want to make these adjustments. And then you would have their app specialist either come in on site or get on the phone and talk with them. And they will say, hey, change this, or they will help you change it. You can, of course, if you have the passcode, go in and make those changes. That said, you have to be careful. Remember, for example, there are 5 parameters. So if you adjust any one of those parameters, it's going to adversely affect, or it's going to affect potentially adversely some of the others. And so if you go in and make this change here, these ones might change also. So you have to be very careful. So going back to that question of how can I know, is this what this is it what pulse length widths is it and whatnot? And so you can go in, and if it says continuous and you don't know if it's true continuous or if it's like 30 frames per second continuous, then you do is you just put your diode in there. And this, I use a Radcal. You can use PTW, you can use, there's a lot of different variety of dosimeters you can buy out there. So they all basically can do the same thing. And here you can see the pulses. And so what I can do is I can count out, I know, let's see here, duration. This was 3.2 seconds. So over these 3.2 seconds, I can count how many pulses I have and obviously divide that by 3.2. That's obviously my pulse per second. Or I can't do that here because it's not hooked. My system's not actually hooked on. If I actually click on this button, actually let me, I'll be darned. And if I zoom in really far, now you can see the pulse width. And I can come over here and I can measure my pulse width. And my pulse width was 3.8 milliseconds right there. Okay. So that's one way to look at this. Obviously, this wasn't a continuous mode. So this is one way for you to go in and check to see what your pulse width is. So if you're doing 7.5 pulses per second, 15 pulses per second, 30 pulses, whatever your pulse rate setting is at the Fluoro unit, you can go measure what your pulse width is, and then you can adjust those two things. So I can go in, as I said, I can go back to here and I can count how many pulses per second I'm getting. So I know what my pulse rate is. Let's see, I think that's even an option. Nope. Nope, it should give me, oh, yeah, that's not the button I wanted. Okay, one of these options would allow me to, there we go. It wasn't letting me pulse count. So there were 25 pulses over 3 seconds. And so I could do some math here. Actually, I think it might give me pulse rate. Pulse count, pulse frequency. There you go. There you go. This was a 7.5 pulse per second, and it was giving me 3.2 second pulse widths. So I'm actually very happy with that. You don't get much better than that, to be frank. I was probably only imaging maybe one PMMA block. If you do now put a bunch of PMMA blocks up there, I'll bet you $10 that pulse width's going to widen out. Your pulse rate will stay constant because that's fixed, but this thing will block out. And I mean, I was having fun that night. So I did a lot of measurements. I'm trying to see if there's a thicker one here. Here you go. Here's 15 pulses per second. So in this case, we can go look at, see how wide these pulse widths were. See, now you can see the pulse width is almost 6.5 milliseconds. So it had to change that, and for whatever reason, to do it. Now, you would think it would actually allow it to go a little smaller, because if it's 15 pulses per second, they're more frequent, so you can actually reduce the amplitude. In this case, they probably reduce the amplitude instead of reducing the width.